Welcome, everyone. Acute psychosis can be one of the most challenging situations in EMS. It refers to a condition where the patient is experiencing a break from reality. They may hear or see things that aren't there, hold false beliefs, or behave bizarrely. These episodes can come on suddenly and be caused by psychiatric illness, drugs, or medical problems. As EMS providers, our role is crucial in keeping everyone safe and getting the patient the help they need. In this training, we'll cover what acute psychosis looks like, how to assess such a patient using the COAST map mnemonic for mental status, and how to manage the situation using de-escalation techniques, proper restraints, and medications when appropriate. The focus is on safety for the patient, for you, and for others, while treating the patient with dignity and compassion. By the end, you should feel more confident in handling psychosis calls in the field. Psychosis itself is not a specific disease, but rather a description of a mental state. In acute psychosis, the individual cannot distinguish what is real from what is not. They may have delusions, which are fixed false beliefs, such as thinking someone is out to harm them despite evidence to the contrary, and hallucinations or perceiving things that aren't actually present, like hearing voices. Their thoughts are often disorganized, what we mean by a profound thought disorder. For example, they might jump between unrelated topics or speak in a word salad that's hard to follow. Behavior can be very abnormal. They might be agitated and yelling at unseen stimuli, or conversely, they could be catatonic and not responding at all. Importantly, psychosis can last for a short time, minutes to hours or days, or be part of a long-standing condition that requires lifelong management. As EMS providers, recognizing that a patient is experiencing psychosis is the first step. This tells us we need to consider safety and an approach that might be very different from a typical medical call. Let's break down what we might see or hear when a patient is psychotic. Hallucinations are a big one. These can be auditory, which are the most common, like hearing voices commenting or commanding, visual, seeing people or creatures that aren't there, or less commonly tactile, feeling bugs crawling on skin, for example. So, a patient might be staring at an empty corner of the room and screaming at the demon they see, or covering their ears because voices are shouting at them. Delusions are false beliefs that the patient fully believes are true. They might insist the government has implanted a chip in their brain, or that they are a famous historical figure, or that strangers on the street are undercover agents plotting against them. You cannot talk someone out of a delusion because it's very real to them. Disorganized speech often accompanies this. The patient's words might be jumbled or jump from topic to topic in a way that doesn't make sense, which is a reflection of disorganized thought processes. Their behavior can be bizarre. They might be wearing multiple coats on a hot day, or acting inappropriately, like shouting rhymes or being unable to sit still. On the other hand, some psychotic patients have a flat affect, show no emotion, even if they're describing terrifying things, or they might laugh at something sad because their emotional responses are distorted. In schizophrenia, a primary psychotic disorder, we often see a lack of interest or pleasure in life activities as well. It's worth noting that not every psychotic patient is agitated or violent. Some may be relatively calm, but deeply internally preoccupied, or their thinking is clearly not in touch with reality. Psychosis is a symptom that has many possible causes. It's critical for us in EMS to keep an open mind about why our patient is psychotic, because that can alter our management and destination decisions. The primary psychiatric causes include disorders like schizophrenia, a complex brain disorder that typically starts in early adulthood and is characterized by chronic or recurrent psychosis. Schizophrenia isn't fully understood, but we know factors like brain chemistry, especially dopamine, brain structure, genetics, and psychosocial stressors contribute. Other psychiatric illnesses can present with psychosis too. For instance, someone with severe bipolar disorder in a manic episode might become psychotic, grandiose delusions, etc., or someone with major depression might in rare cases develop psychotic depression like delusions of worthlessness. Substances are another big category. Certain drugs can induce psychosis in anyone. For example, high doses of stimulants like meth or cocaine can cause paranoid delusions and hallucinations. Hallucinogens, by definition, cause hallucinations. Even heavy marijuana use can trigger psychosis in vulnerable individuals. On the flip side, withdrawal from substances like alcohol withdrawal, delirium, or benzodiazepine withdrawal can also cause hallucinations and confusion. As EMS professionals, we should always look for signs of drug use like paraphernalia or bystander reports if a patient is acutely psychotic. We must not forget medical causes. Conditions causing delirium or an acute confused state can mimic psychosis or include psychotic symptoms. A classic example is low blood sugar. A diabetic with hypoglycemia might be combative or hallucinating, but will improve with glucose. Infections, especially in older patients, like a urinary tract infection or sepsis, can cause delirium with hallucinations. Head injuries or strokes can present with abnormal behavior. Even lack of oxygen or high fevers can lead to confusion and psychotic like states. The key difference is that these patients have an underlying medical problem causing brain dysfunction, and often their mental status fluctuates more, 1 minute combative, next exhausted. However, in the field, it may be hard to tell psychotic disorder from delirium, so we treat it as a medical emergency regardless and look for clues of medical issues. Acute stress can precipitate a brief psychotic break in rare cases. For instance, someone experiencing a severe trauma might briefly lose touch with reality. There's also a condition called brief psychotic disorder that can happen around extreme stress. Sleep deprivation can also cause hallucinations. These tend to be short lived, and the person recovers once stress is mitigated or sleep is achieved. Often things are mixed. For example, a person with schizophrenia who uses meth will be especially prone to a psychotic episode. Or a patient initially thought to have a primary psych issue might turn out to have taken a substance or have a medical problem compounding it. A recent 2024 consensus on acute behavioral emergencies emphasizes that many of these crises involve overlapping factors: mental health, substances, and medical conditions. Because of this, we need to consider all of the above when assessing these patients. We won't dive too deep into neuroscience, but a little understanding of why psychosis happens helps make sense of the treatments. The dopamine hypothesis of schizophrenia is a fundamental concept. Basically, researchers found that too much dopamine signaling in the mesolimbic pathway of the brain is associated with hallucinations and delusions. That's why drugs like haloperidol, a dopamine antagonist, can reduce those symptoms. Meanwhile, reduced dopamine in another pathway, mesocortical, might cause the negative symptoms, like flat affect or lack of motivation. So, brain chemistry is a big part. An imbalance in neurotransmitters can distort perception and thought. Serotonin is another. Atypical antipsychotics also work on serotonin receptors, and drugs like LSD, which cause hallucinations, act on serotonin receptors, so that system is involved too. Glutamate, the main excitatory neurotransmitter, is a newer area of research. For instance, PCP and ketamine can cause psychosis like states by blocking NMDA glutamate receptors, suggesting glutamate underactivity might also play a role in schizophrenia. Genetically, we know schizophrenia and related disorders tend to cluster in families. No single psychosis gene, but multiple genes increase risk. Brain imaging sometimes shows differences in brain volume or activity in people with chronic psychosis. So there are real physiologic changes underlying psychiatric illnesses. It's not just all in their head in the dismissive sense, it's in their brain biology. For substance induced psychosis, the mechanism is often the drug's direct effect on brain chemistry. Methamphetamine, for example, causes an excessive release of dopamine, essentially oversaturating those receptors and leading to paranoia and hallucinations similar to schizophrenia, but usually more short lived if the drug wears off. Cocaine has a similar effect of increasing dopamine. Hallucinogens like LSD mimic serotonin and massively alter sensory processing in the brain, hence the vivid hallucinations. Even high dose marijuana can trigger psychosis by its complex effects on cannabinoid receptors and dopamine downstream. When medical issues cause psychosis, more accurately termed delirium in many cases, it's often because the brain is under systemic stress. High fever, infection, metabolic derangements, like liver or kidney failure causing toxin buildup, lack of oxygen, etc., all impair normal brain function. The result can be confusion, disorientation, and hallucinations. Unlike primary psychosis, delirium is typically global brain dysfunction and often fluctuates more, but in the moment it can look very similar. Stress hormones and sleep deprivation can also alter neurotransmitters. Extreme conditions, like being awake for days or experiencing combat, can lead to temporary psychosis, likely because of a mix of neurotransmitter depletion and hormonal extremes. The takeaway? Psychosis is rooted in physical changes in the brain. This is why medications that target brain chemistry and other medical interventions can be effective. It also reminds us that a psychotic patient is a medical patient. Something physiological is happening, even if it's a psychiatric disorder. Assessing a psychotic patient starts even before you reach the patient. In psych calls, scene safety is paramount. Take a moment as you arrive to scan for hazards. Is the patient in an unsafe location, like wandering in traffic or on a rooftop? Are they holding any potential weapons or objects that could be used to harm you or themselves? Are there multiple patients or bystanders who are agitated? You may need law enforcement to secure the area or even stage until they declare it safe if there's a threat of violence. Remember, a person in a severe psychotic episode might be unpredictable. One moment passive, the next moment aggressive if they perceive you as a threat due to their delusion. Ensure you have an escape route and do not let the patient come between you and the exit. Ideally, have only a couple of rescuers approach initially while others stay back ready to assist if things go wrong. The first rule is scene safety. You can't help the patient if you become a victim. Once it's reasonably safe to engage, do a rapid medical evaluation. Just because someone seems crazy doesn't mean they aren't also sick or injured. Look at their overall condition. Are they breathing okay? Any signs of trauma? Maybe they got hurt during their bizarre behavior? Take vital signs early if you can do so safely, especially blood glucose, because hypoglycemia is easy to treat and crucial not to miss. Also consider, does this patient need oxygen? If they're hyperventilating or in a stimulant overdose, they might be hypoxic or acidotic. Try to get a pulse ox. If they are extremely diaphoretic, hot to touch, with superhuman strength and agitation, think about excited delirium, which can be due to stimulants or certain syndromes. That's a true medical emergency. They can overheat and collapse. So, treat whatever medical issues you find. If the glucometer reads low, treat with dextrose. If they're injured, do what you can to control bleeding, etc. Keeping in mind you may have limited cooperation. Performing a mental status exam on a psychotic patient can be challenging, and a thorough exam is rarely possible in the field. But using the Coast Map framework gives you a checklist, so you don't forget key components, and it helps you objectively describe the patient's mental state in your report. Even if you can't do it formally, observe and ask simple questions to gauge orientation. Do they know who and where they are? Memory, thought content, etc. This not only guides your care, but also is important for determining if they have the capacity to make decisions. Decision making capacity is crucial in these calls. A patient with capacity can refuse care. One without capacity can be treated under implied consent or in conjunction with police using mental health hold procedures. A person actively psychotic, delusional, not oriented, not understanding the situation, usually cannot rationally weigh risks and benefits to decide on refusal. For example, a man who believes aliens are controlling the hospital likely isn't capable of informed refusal of transport. Document their mental status to back this up, and involve law enforcement if you need to take them involuntarily for evaluation. Many jurisdictions allow police to place a psychiatric hold for evaluation if someone is a danger or unable to care for themselves due to mental illness. You might contact medical control for guidance or orders if the patient is refusing, but clearly needs help. While interacting, try to gather history from anyone around. Has he been acting like this before? Does he take any medications? Did anyone see him take drugs or get hurt? Sometimes family or friends can tell you, oh, he has schizophrenia and stopped his meds a week ago, which immediately gives you context. Or a buddy might say, we think he smoked something at a party. Such info is gold. Also, check for any medical bracelets or wallet cards, maybe indicating a condition. Check the environment for clues, pill bottles, drug paraphernalia, strange writings on the wall, etc., which might help piece together what's going on. CoastMap is a convenient checklist to perform and document a mental status exam in the field. Let's go through each component with an example or two. Consciousness. This is basically how awake and responsive the patient is. Most psychiatric patients will be alert, but someone who's taken an overdose or has an underlying medical issue might have altered consciousness. For instance, a schizophrenic patient off meds will likely be wide awake and hypervigilant, whereas a person high on PCP might drift in and out. Also, pay attention to how well they can concentrate on questions. A psychotic patient might be so distracted by internal stimuli, like voices, that they can't pay attention to you for more than a second or two. That in itself is a useful observation. Orientation. Ask simple questions. Can you tell me your name? Do you know where you are right now? What's today's date? Do you know why we're here? Often you'll get wrong answers or strange answers if they're psychotic. For example, they might say the date is 2050, or they might name themselves as someone else. Note not just if they're correct, but also how they answer. If you ask, where are we? And they immediately say, we're in the CIA headquarters, and you're actually on a street corner, that's clearly disoriented. If they hesitate and take a long time to respond, that sluggishness or confusion is also notable. Orientation is important because disorientation could mean a delirium or organic issue, but even psychiatric patients can be disoriented in severe cases. Activity. Look at their overall psychomotor activity. Are they hyperactive, pacing, fidgeting, unable to sit still? Or are they oddly still? For example, some psychotic patients might be frozen in place, catatonic, or doing something repetitive like rocking. Can they follow basic instructions like stand over here, or are they too disorganized or resistant? If someone is actively a danger, like charging around or throwing items, that obviously heightens the need for safety interventions. Note also if their movements are purposeful or not. An aimless, undirected level of activity, like wandering aimlessly or suddenly flailing, might indicate a different issue than a focused aggression, like coming at officers, which might be driven by a paranoid delusion about the officers. Speech. How is the patient talking? One psychotic patient might be speaking a mile a minute in a loud, pressured tone about random topics, called a flight of ideas, common in mania or stimulant intoxication. Another might be hardly speaking at all or only in whispers. Note if their speech is coherent. They might string together sentences that make no sense. The dog is red because I am the flying spaghetti. This is word salad or severely disorganized speech, or they might make up new words. Also, listen for signs of a thought disorder through their speech, like loose associations. Their answer kind of connects tangentially, or clang associations, rhyming words. In short, is their speech normal in rate, volume, and does it make sense contextually? Thought. This overlaps with speech content. You're trying to get at what they are thinking about. Ask open ended questions if possible. Can you tell me what you're experiencing? Or, why do you think you feel this way? They might reveal a delusion. I feel this way because the aliens have been zapping me with energy at night. Are they paranoid? Do they think people are out to get them? Are they expressing hopeless or bizarre thoughts? Also, are they suicidal or homicidal? That's critical to find out in any psychiatric emergency. It might be hard to directly ask if they want to hurt themselves or others, but look for clues or ask indirectly if you suspect. The organization of their thought can be judged by how they answer you. A coherent narrative versus a completely nonsensical one indicates the degree of thought disorder. Memory. Testing memory on scene might be limited, but you can gauge short term memory with something simple like introducing yourself and then later asking if they remember your name, or ask what they did earlier that day. Long term memory, like asking their birthday or past events, might be intact even in psychosis, unless there's something like dementia or an organic issue. Significant memory gaps or confusion might point to a medical delirium or intoxication rather than pure psychiatric illness. Memory issues aren't usually front and center in psychosis, but sometimes their answers can show confabulation or confusion. For example, they might say they haven't eaten in 5 years, obviously not true, indicating a break with reality. Affect and mood. This is about their emotional state. Mood is what they report. I feel great or I feel scared. And affect is what you observe, their facial expression and vibe. In psychosis, these can be mismatched or inappropriate. They might be laughing while describing something terrifying, incongruent affect, or have a flat affect. No expression at all, monotone voice, even though they're talking about emotional topics. Or their mood might be very volatile, rapidly shifting from calm to irate to tearful. Note these because they can help differentiate conditions. A flat affect and lack of emotional response might be more schizophrenia, whereas extreme mood swings could suggest a manic episode or drug effect. Keep in mind also that a patient might be very anxious or fearful if they are hallucinating scary things or paranoid about you. Perception. Here we're concerned with hallucinations and misperceptions. Often you'll gather this from their behavior. They're responding to voices or looking at things that aren't there. You can also ask them in a gentle, non confrontational way, are you hearing voices right now? Or what do you see? It's important to approach this in an accepting tone. If you act judgmental or tell them there's nothing there, you're imagining it, it could break rapport. Instead, you might say, I'm not hearing those voices, but I believe that you are. What are they saying to you? If the voices are commanding them to do something harmful, that's crucial to know. Also, sometimes patients will not voluntarily tell you about hallucinations until asked, perhaps out of fear. So perception checks are key. Hallucinations are a clear sign of psychosis. In some cases, they might have illusions, misinterpreting real stimuli, like thinking the ambulance siren is people screaming. Overall, COSMAP gives you a structured way to document what's essentially an altered mental status. It helps communicate to the receiving hospital and in your report what the patient's mental state was. It can also guide your care. For example, if the patient is not oriented and hallucinating, perception issues, you know they likely lack capacity and you'll treat accordingly. We will wrap up the first part of this lecture here. In the next part, we will go over some scenarios and how you may handle them in the field. See you then.